Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
Let's talk about what happens to a drug after it's done its job in the body. I mean, where does it actually go? Today, we're diving deep into the body's incredible disposal system, and we're going to focus on the absolute powerhouse of drug clearance, the kidney. You know, mastering this isn't just for exams. It's fundamental to using medications safely and effectively with real patients. So, here's our plan. We'll kick things off with the kidney's central role. Then we'll literally trace a drug's path through the nephron. After that, we get really practical. We'll look at how we can actually manipulate excretion, what factors can mess with it, and finally, the absolutely crucial skill of adjusting doses when a patient's kidneys aren't working at 100%. Okay, so the body has a few ways to get rid of drugs, through bile, the lungs, even sweat. But let's be crystal clear. When it comes to the heavy lifting of drug clearance, the kidney is in a league of its own. It is the primary facility for removing the vast majority of drugs and their metabolites from our system. So how in the world does the kidney pull off this incredible feat? Well, the secret lies within millions of tiny, microscopic functional units. So let's zoom in and take a little journey through one of them, the nephron. Think of this as our roadmap. This is the nephron. We're going to follow a single drug molecule as it navigates three crucial checkpoints: filtration, secretion, and reabsorption. Each one is like a security checkpoint that determines the drug's ultimate fate. Does it get kicked out of the body, or does it get sent back into circulation for another pass? Our journey begins right at the first checkpoint, glomerular filtration. I want you to picture a really high-pressure, superfine sieve. This is the very first encounter between the drug in the blood and the kidney's sophisticated sorting system. Now, this filter has some pretty strict rules. First off, size matters. Only small, low molecular weight drugs can even get through the pores. Second, the drug has to be free. If it's attached to a big protein like albumin, it's like being handcuffed to a bouncer. There's no way it's getting past the velvet rope. And finally, this whole process favors drugs that are water-soluble, or polar. And what drives it all? Simple physics. Hydrostatic pressure, just physically pushing the right kind of drugs out of the blood and into the tubule. So, looking back at our map, you can see the glomerulus right there at the very beginning. This is where that first critical sorting decision happens. The small, free, water-soluble drugs pass through, officially starting their journey towards excretion. But what about all those drugs that couldn't get through the filter? The ones that were too big or were bound to protein? Well, the kidney has a very clever backup plan. Welcome to step 2, active tubular secretion. Now, unlike that first step, this is an active process. It's happening in the proximal tubules, and it uses energy to power these little molecular pumps that literally grab drugs from the blood and shove them into the tubule. These pumps are strong. They can even move drugs against their concentration gradient. But they do have a weakness. They can be saturated. They can get overwhelmed. This is a huge deal because it's a key point for drug-drug interactions. The classic prototype here is penicillin. It's often bound to protein and doesn't get filtered well, but these active pumps make sure it gets cleared out efficiently. And right here, you can see exactly where this is all going down. See how the capillaries wrap so tightly around the tubule? That's where these little pumps are working overtime, yanking drugs out of the blood and into the urine, giving the body a second, very powerful chance to get them out. Okay, so our drug has made it into the tubule, either by filtration or secretion. It's on the fast track to the bladder. But hold on, there is one final major twist in this story, and it's called Step 3, tubular reabsorption. This is basically the body's last chance to pull something back from the brink. Now, reabsorption comes in two main flavors. You've got active reabsorption for stuff the body desperately wants to keep, things like glucose or vitamins. But for us, in pharmacology, the really interesting one is passive reabsorption. This is the secret escape hatch for lipid-soluble drugs. Because they can slip through cell membranes so easily, they just diffuse from the high concentration in the tubule right back into the low concentration in the blood, effectively dodging excretion. This process happens all along the tubule, but especially down in the distal parts. It really is the final gatekeeper. Lipid-soluble drugs, they can just waltz right back across into the blood, which extends their half-life. But what about those water-soluble, polar drugs? Well, they're trapped. They can't cross the lipid membrane of the tubule cells, so they have no choice but to stay in the urine and get excreted. So now that we understand these three checkpoints, this is where we can get really clever as clinicians. This isn't just abstract physiology. These are rules that we can actually bend to our advantage. Let's talk about how we can manipulate drug excretion for a therapeutic benefit. Let's look at a classic high-yield example, probenecid. It works by blocking those active secretion pumps we were just talking about. And this one action can be both a good thing and a bad thing. For instance, if you give it with penicillin, probenecid blocks penicillin's secretion. That keeps penicillin levels in the blood higher for longer, a huge therapeutic win, especially back in the day. But if your patient is taking an antibiotic like nitrofurantoin for a UTI, that same mechanism is a disaster. Nitrofurantoin has to get into the urine to work, and probenecid blocks that from happening, leading to treatment failure. All right, here's another brilliant clinical move, one you'll see in toxicology all the time. It's called ion trapping. Remember how those lipid-soluble drugs could sneak back into the blood? Well, we can prevent that. Most drugs are weak acids or bases, so by changing the pH of the urine, we can force them into their ionized, water-soluble form. We essentially trap them in the urine. So for an overdose of an acidic drug like aspirin, we make the urine alkaline. For a basic drug like amphetamine, we make the urine acidic. The drug becomes charged, it can't be reabsorbed, and it gets flushed out of the body way faster. This is a genuine life-saving technique. Of course, this whole elegant process isn't happening in a bubble. It's incredibly dynamic and it's influenced by a whole bunch of factors, both related to the drug itself and, of course, to the patient. So on the drug side, we've already seen how critical things like lipid solubility and protein binding are. For the patient, age is a huge one. Kidney function is just naturally lower in newborns and in the elderly. But the absolute king, the most important factor of all, is renal blood flow. Any disease that reduces blood flow to the kidneys, think about congestive heart failure, a major hemorrhage, or chronic damage from diabetes, is going to directly slam the brakes on drug excretion, and that can lead to toxic accumulation fast. And that leads us directly to the most practical, real-world application of everything we've just covered. What do we actually do when we know a patient's kidneys are compromised? How do we dose medications safely when their clearance system is impaired? Well, one of our most important tools is the Cockcroft-Gault equation. It's a classic formula that takes a patient's age, weight, and their serum creatinine level, and it gives us an estimate of how well their kidneys are working. We use creatinine because it's a waste product that's filtered pretty predictably, so its clearance gives us a really good proxy for the glomerular filtration rate, or GFR, which is our best overall snapshot of kidney function. So let's make this real. Imagine a 60-year-old female, 80 kilograms, with a high serum creatinine of 3. She needs an antiviral, tenofovir. We plug her numbers into the Cockcroft-Gault equation, and it spits out a creatinine clearance of just 23.5 milliliters per minute. That's really low. It's severely impaired. Looking at the drugs guidelines, we know a standard daily dose would be toxic for her. So the dose has to be adjusted, in this case to 300 milligrams only every 3 to 4 days. That is applied pharmacology right there, preventing a serious adverse event. And tenofovir is just one of many. This table is incredibly high yield for exams because it highlights some of the major drug classes you absolutely have to think about in renal impairment. We're talking about very common antibiotics, cardiovascular drugs like digoxin and lithium, powerful immunosuppressants, and many chemo agents. Knowing this list is essential for safe prescribing. Okay, let's do a quick recap of the biggest takeaways. Remember, polar drugs get trapped and are easily excreted. Lipid-soluble drugs can sneak back and are easily reabsorbed. We can mess with urine pH to kick drugs out faster in an overdose. Protein binding slows everything down. Competition for those active pumps can change a drug's half-life. And, most importantly, if renal blood flow goes down, drug excretion goes down with it. So I'll leave you with one final question to tie all this together. The kidneys rely on chemical messengers called prostaglandins to keep blood flowing, especially when they're under stress from things like dehydration or heart failure. So, knowing that, which extremely common over-the-counter drug class works by blocking prostaglandins, and therefore poses a major hidden risk to that vital renal blood flow, particularly in our most vulnerable patients. It's a critical connection to make between basic science and everyday clinical practice.